as Yinting mentioned, today we will talk about the EPIC-PCD study, and we will focus a bit on the upper airways of people with PCD. Yinting kindly introduced me and Vasiliki. I just wanted to say that we have a team that works since many years on the epidemiology of PCD, and we work on several national and large international projects. Today we will focus on EPIC-PCD, but there are several other studies. And we, of course, work in the framework of BEAT-PCD in a lot of collaborative projects with patient representatives, clinicians, and scientists. So today we will focus on EPIC-PCD. We will first give you an overview on upper airway disease in PCD. A disclaimer, I'm not an ENT specialist. However, through my research, I have a very good overview of not only of the existing literature of PCD, but also of patient data related to the upper airways. And then we will talk a bit about aspects of pathophysiology and the manifestations from the upper airways. And then we will talk more specifically about the EPIC-PCD study, its aims and study design, the current status and recruitment, what we have found up to date, and what we are working on right now, where Vasiliki will also show us some preliminary data that no one else has seen so far. So that will be the first time that we saw this and the next steps for the study. So this study is also a study that is ongoing in the framework of work package 6 of BEAT-PCD, which is the work package focusing on neglected research areas. I don't need in this audience to talk a lot about the different multi-organ manifestations of PCD. I just wanted to focus on the fact that the respiratory motile cilia, they are affected throughout the airways, and that doesn't mean only the lower respiratory tract, but also the upper respiratory tract. That means that in most patients, we have, due to the impaired mucociliary clearance, manifestations also from the upper airways. These manifestations start with the mucostasis and build up.
They are also in charge of reporting.
This mucostasis creates a breeding ground for bacteria that leads to recurrent infections. It leads to chronic inflammation from the lower and the upper airways, and it leads to permanent damage of the airways. And in the upper airways, it's an area that I would say much better now, but 5 years ago, when we started with the study, it was really a neglected area of major morbidity. And the reason was that naturally, most research in the past decade focused on the lower airways because it is the main cause of morbidity in people with PCD, especially people who develop bronchiectasis. Another big issue, however, is that our understanding about upper airway disease was quite limited. We knew that upper airways were affected, but it was mostly seen as a side problem that patients with PCD have, as we say also with issues like fertility problems or other manifestations from other organ systems. Most of the knowledge that we had until recently on the upper airways came from clinical experience. So if you would talk with an ENT specialist that is following up many patients with PCD, they could tell you, they could give you a very good overview of the problems that people with PCD would have and share their experience, but this was not really recorded in the literature. And the actual literature evidence was quite limited. They would come from small single-center studies, and almost all of them were cross-sectional studies. And very importantly, which is quite common in PCD, most of the studies would cover only the pediatric population or up to young adults. The information in a lot of the studies published in the past years, they would come from clinical charts, and they would not be standardized with a lot of missing information. And of course, we will rarely have standardized information directly from patients. However, as I said, based on the pathophysiology of the disease, we know that the upper airway disease is a major cause of morbidity for PCD. The symptoms are common and they are burdensome, and they begin soon after birth for many of the patients and persist actually throughout life. And almost all patients suffer from upper airway problems. Starting with sinonasal disease, we know that rhinorrhea is usually one of the first symptoms that a baby with PCD might manifest with. So they will have this runny nose often from infancy, from the first few days of life. And very commonly with increasing age, they will suffer also from postnasal drip that will also affect their sleep and
Gemide nasıl olduğu bilemiyor ama.
Gemideydi çünkü.
Thank you for keeping your microphones muted. So the accumulation of mucus that is constant due to the rhinorrhea in the nasal cavity and the sinuses, as we mentioned, it creates this breeding ground for bacteria that leads to recurrent episodes of sinusitis. We know for the sinonasal disease that they seem to be worse with age. The situation is not always the same with the years. We will talk about the otological symptoms later. This often leads to the development of chronic rhinosinusitis, and a lot of people with PCD have chronic rhinosinusitis that can also lead to impaired sense of smell. From the nasal endoscopy, from the ENT examination, people with PCD often have signs of inflammation of the mucosa, and then they have these characteristic sticky strings of mucus that it's attached to the nasal turbinates, as you can see in the upper photo of the nasal endoscopy on the right. And they, in general, have a lot of accumulation in the mucus in the nasal cavity and in the sinuses. Polyps are a big discussion in PCD. We know that people with PCD have polyps more frequently than the general population, but we don't know if this is really a very frequent, or at least we didn't know until some years ago if this is really very frequent. However, independently of polyps, there are also other reasons of nasal obstruction in PCD, mostly the turbinates that many times they tend to be hypertrophic, leading to this sensation of blocked nose. There is also publications about issues with the development of the paranasal sinuses, mainly hypoplasia or aplasia, and some more recent publications that show also that the pneumatization of the paranasal sinuses in people with PCD is affected, with people with PCD having smaller volumes compared to patients that have CF or that they have chronic rhinosinusitis with polyps. So all these symptoms and manifestations, they do affect the quality of daily life because they're constant and bothersome, but they also affect the quality of sleep. This way, they often have impact on school, work, and productivity. But the issue is that the symptoms are persistent and the patients grow accustomed. So very often, people with PCD will underreport their problems from the upper airways because they are not as striking as some of the infections from the lower airways, and they are constantly there. Is what we say, this is their normal. So it's very difficult for them to recognize that this is not how their upper airways should work. Regarding the ears, the ciliary function is impaired in the middle ear epithelium, and that also leads to recurrent episodes of otitis media. This is particularly common in childhood, and the reason is that compared to the adults, the Eustachian tubes in children are shorter, more narrow, and more horizontal. So the children anyway, they're more prone to ear infections compared to adults. And this improves with age in the healthy population and in people with PCD. However, the PCD often leads to otitis media with infusion after all these recurrent episodes of otitis that most of the times is bilateral. And in healthy children, This otitis media with diffusion usually resolves spontaneously after a few episodes of otitis if they have them, but in PCD it persists, and many times it needs some kind of management that we will discuss a bit later in the presentation. So we know that for the ears, infection seems to improve with age, but there is very little data. What always surprised me, since I started focusing my research on the upper airways, is how many physicians that treat adult patients, pulmonologists especially, they have this impression that adults with PCD don't have really lots of problems from the ear. So this shows that we don't have enough data, and it is an important area to research. So in otoscopy, signs of disease, we commonly see signs of otitis media with infusion. We can see tympanic retraction or perforation, and often due to the repeated infections, we see myringosclerosis. If the patient has not yet been diagnosed with PCD, especially for people that were diagnosed later in life, it is extremely common due to the otitis media with diffusion that the people have been undergone myringotomy and ventilation tube insertion, which however has very poor results in PCD, and it leads to persistent ear discharge, which is very, very unpleasant, and a lot of children with PCD complain about the ventilation tubes, that they don't work, they don't make the situation better, and the ear discharge persists. So we talked about infections. However, something very important for otologic disease in PCD is that otitis media with infusion often leads to conductive hearing loss already in childhood, especially because of the fluid behind the tympanic membrane. However, with age, this hearing loss can be often mixed. So in addition to the conductive hearing loss, we possibly have appearance of sensorineural hearing loss due to chronic ear inflammation. Hearing impairment is not always bilateral. That's why it's difficult to recognize, because many patients might have problems mainly from the one of the two ears or have more impairment in one and still have quite good hearing from the other one. So they still can act normally in their daily life. However, in situations where their hearing needs to be very good, it's easier to recognize that they have issues. If hearing impairment develops early in life, it might also impair speech development and learning and educational outcomes. A very important concept is that we have seen being researched and discussed in other diseases, especially asthma and polyposis, is the unified airway concept. And this is a concept that makes a lot of sense for PCD because the mucociliary clearance is impaired throughout the whole respiratory system. And there are also small studies with few patients, however, still indicative that the sinuses could be a potential bacterial reservoir for pulmonary recolonization. So this is something that is very important and shows that we cannot only focus on the lungs, but we have, when we study PCD or when we treat people with PCD, try to assess also the symptoms from the upper airways. Regarding management, some of the most common management approaches for PCD, they focus on symptom management, they focus on improving mucociliary clearance and control infection. In general, we know that there are very few RCTs for PCD, and these are all for the lower airways. There is no evidence base specific for the upper airway management for PCD. However, for medical management, some of the most common practices is, of course, nasal rinsing. This is very, very important. And I think it is very characteristic that patients, although it's something not quite pleasant, patients really tend to do it because they see a big difference in how it frees up their airways. Many patients also do inhalations for the upper airways, Of course, they take antibiotics when needed for the recurrent infections. There is, however, no standardized eradication strategies for bacterial sinus colonization in the same way that there are eradication strategies for some bacteria for lung colonization. There are also some additional medication for the nose, like nasal steroids or antihistamines. Sometimes the ENT specialists will recommend ear rinsing to clear up, especially the ears when there are repeated infections, but also ear steroid or antibiotic drops. One of the most important management aspects of PCD is, of course, the use of hearing aids. And there are hearing aids that you can just wear, which are usually air conduction hearing aids. And then there are the bone conduction hearing aids. Some of them also are wearable, which are the non-invasive ones, and some they need to be screwed on, and they are the invasive one. There are several indications that show that when a person has otitis media with effusion, of course, the air conduction doesn't work because there is fluid on the way. So it is quite important to also try if the bone conduction will work much better. The issue with hearing aids is, of course, that a lot of patients, especially children, that they have hearing problems due to the repeated infections, they do not want them. So I would say these are underused and hearing impairment in PCD is under treatment. There are also some surgical approaches being used. These are not as common, and they are for specific, more severe occasions, like functional endoscopic, sinus surgery. I'm sorry, I think that Yinting, have you sent me a message?
No, I have not.
Okay. Sorry for the interruption. There was a weird pop-up in my screen. So functional endoscopic sinus surgery has been used in cases of persistent chronic rhinosinusitis where the sinuses are really affected, and it's being used as a way also to clean up the sinuses. And there are some studies that they show that it has quite good results for these people. Of course, polypectomy in case that there are large polyps, turbinoplasty or turbinectomy. And I already mentioned earlier that myringotomy with insertion of ventilation tubes or tympanoplasty can be used in case there is the need to drain the liquid from the medium ear, or in case the tympanic membrane is really affected or it has been torn. So for all these reasons, we wanted to see more an overview of the data that exists for the symptoms and manifestations of upper airways disease and PCD. These are some data from a systematic review that I had done several years ago, and the only reason that I want to show this is that we try to summarize the prevalence of different manifestations. And here I have sinusitis and otitis as examples of upper airways manifestations. And we have seen a huge heterogeneity in the prevalence reported in published literature, both for sinusitis and for otitis, which shown that these studies have a lot of differences in design, in the way that all these manifestations were reported and recorded and assessed. So it is quite important to try and find more valid data. This is also recently accepted. It still says in revision because when I did the slides, it was not yet accepted. work that we did with Yinting, where we ask patients which are their priorities for PCD research. And I want to focus here that one among the identified priorities from people with PCDs or with PCD or parents of children with PCD were hearing problems and ENT symptoms in general. These are the reasons that made me think that we need something like EPIC-PCD some years ago. And these are all the things that gave birth to the EPIC-PCD study, trying to fill the evidence gaps for the upper airway. So the EPIC-PCD study is the ear, nose, throat prospective international cohort of patients with PCD. And it has several aims. First of all, to characterize sinonasal and otologic problems in PCD patients, to study associations between ENT and pulmonary disease in PCD, study differences in ENT management across centers, and as a cohort, even more importantly, to describe the course of ENT disease. As I mentioned, these are evidence that we lack, how the ENT disease progresses with time, and identify determinants of short-term and long-term disease prognosis. So this is a prospective multi-center observational study. It is nested in routine care, so the patients do not have to undergo additional examinations compared to what they do routinely. It recruits both children and adults, and we collect patient-reported information and objective clinical test results in a standardized way using PCD-specific instrument like the Follow PCD form, that also includes the Follow PCD patient questionnaire, or the QoL-PCD instrument for quality of life. We set up the cohort in 2020. This was the work for Yinting's PhD. And in 2024, end of 2024, I received further funding. And we could, from the Swiss National Science Foundation and the Swiss Lung Association, so we can continue this work. And Vasiliki and Nena Karavasiloglu, our postdoc, joined this project so that we can expand further the aims and focus on prognosis. So the study design of EPIC-PCD is quite simple, I would say, since we want it to be nested in routine care and we want most of the people to accept to participate. So when a patient joins the study, they go to their routine clinical follow-up visit. So we call this a baseline visit. So we collect results from ENT examinations, and also they complete the Follow PCD patient questionnaire. In addition, from the charts, we get information from diagnostic tests and from some other clinical examinations, like, for example, lung function. And for each follow-up, that depends on the study local protocol. That can be every 3 months or 6 months, but at least once a year. We collect information from the ENT examinations and the questionnaire, but we also collect other clinical examinations or also information about ENT management. So these are the data. This is an extensive table of data that are collected, but these are the minimum data set that is collected. So as I explained, that are results from ENT examinations, spirometry when it's performed, information on ENT management, of course, the Follow PCD patient questionnaire, and diagnostic information and some simple baseline medical history. For example, if they have bronchiectasis already, if they have had any history of ENT surgeries, and this kind of information. And additionally, if they are available, we also collect some less frequent ENT examinations or information on quality of life. We use the Follow PCD form. The Follow PCD form has been developed a few years ago, and it includes several standardized clinical modules. So we use especially the module for examination of the upper airways and ears. And also we use the Follow PCD questionnaire, which is the last 2 modules that have been developed as a questionnaire for parents of children 0 to 13 years, or adolescents and adult patients who complete it on their own. This questionnaire collects in a standardized way information, quite extensive information about symptoms from the upper and lower airways and about health-related behaviors like exercise. So I think this is the last slide from my side, and then Vasiliki can take over. We have, this is a bit of an overview of the current status of EPIC-PCD. We have now 15 centers from 11 countries that have joined the study. In red, we have the two newer centers from Ankara, the Gazi Center, and in Athens that they recently joined. And this really allows us to have a very good overview of people with PCD followed up in Europe. And the study is still open for new centers to join. And we have several more centers that have expressed their interest in participating. So I will continue going through the slides, but I would let Vasiliki go on with the rest of the presentation.
Thank you, Myrona. Can you hear me? Okay. Yes. Okay. So thank you very much, Myrona. So as Myrona mentioned, I will say a few words and present you the current status of EPIC-PCD study. Also, I will present briefly some already published scientific results of EPIC-PCD study and some results, preliminary results of our current project. So as far as EPIC-PCD recruitment of patients is concerned, currently EPIC-PCD includes 619 patients, and from almost 500 patients, we have available at least one ENT clinical visit and follow PCD patient questionnaire completed at the same day or within 14 days. So as you can also see here in the graph, we have tried to visualize the recruitment in EPIC-PCD study over the time. So each of the point represents an ENT clinical visit and also a patient, a follow PCD patient questionnaire that is completed at the same date or within 14 days. And each line represents one specific individual participant of EPIC-PCD study. The different grade in the colors has to do with the different entry date of each participant. So now I will try to briefly no, Myrona, it's okay. You can go forward. Okay. So now I will briefly present some important, as I said, already published scientific outputs of EPIC-PCD study. So in case if you are interested in more details about this publication, you can find the reference of each publication at the bottom left of each slide. So the first findings, important findings of EPIC-PCD study have to do with sinonasal disease. So frequent nasal symptoms were reported by 52% of the participants of EPIC-PCD study, while 41% reported that these symptoms also persist over the time. All the time. So nasal polyps was found in 14% of the assessed participants, which is substantially higher than in the general population. Also, some other clinical signs that were frequent and reported from nasal endoscopy was hypertrophic nasal turbinates, and which were also very common. As you can see, we have also some an image here to see. And as you can see in the graph that is going forward, the clinical manifestation of sinonasal disease persists with age. And as age and with age 10 years and older, age 10 years and older is associated with a higher risk of sinonasal disease. So the next important finding of EPIC-PCD has to do with otologic disease. So for otologic disease, 31% of the participants had in the clinical examination otitis media with effusion, and 44% of them had hearing impairment. Tympanic sclerosis was present in 18%, which is an indication of a chronic ear infection and a sequela of the chronic disease of this patient with PCD. So as you can see here in the graph, patient-reported symptoms like ear pain, ear discharge, and hearing problems were more frequently reported in older ages. And as you can also see in the other graph that we have presented here, there is a higher risk of, I would like to say that the team has constructed two composite scores. The first one has to do with ear inflammation and the other one with hearing score, summarizing some important symptoms and clinical findings, each of them. And as you can see here in this graph, for ear inflammation score, season seems to be related with a higher risk, and more specifically, autumn in season is related with a higher risk, for example, compared with spring. Whereas for the hearing impairment and hearing score, age seems to play an important role, and more specifically, age 30 years and older was the main risk factor associated with higher impairment scores. And also this risk seems to persist with age. So in this publication, the team analyzes the relationship between patients reporting symptoms and regarding the upper airway disease and objective findings from clinical examination. So agreement was measured using unweighted cohorts, kappa statistic coefficient. And as you can see here, there were no significant correlation found for most of the tested combination between patient-reported symptoms, even for the upper, even for the otologic, and or even with the sinonasal disease and the equivalent examination findings. More specifically, we can also see that the ear discharge, for example, as a patient-reported symptom, correlated poorly with ear discharge found at ENT examination. And we can say that the best correlation was found between reporting hearing problems and audiometry objective results, but this still was weak, as you can see from the kappa. So same image was also in the examples that are summarized here and referred for the sinonasal disease. So from this publication, we can conclude that many PCD patients underestimate or overestimate their symptoms, and this is something that could really be possible in patients with chronic diseases. And as a take-home message, we can say that regular ENT consultation are needed, even though when patients reported not so severe clinical symptoms, severe symptoms. So in this analysis now, the team tries to demonstrate a link between patient-reported upper and lower airway symptoms, and indeed they found a strong association between upper airway disease and symptoms and chronic rhinosinusitis and lower respiratory symptoms. So as you can see here in the graph, a symptom of lower airway disease, like for example shortness of breath, was associated with several upper airway issues that are not summarized here. For example, nasal symptoms, ear pain, but the most one important finding was that they were associated with chronic rhinosinusitis. Also, sputum production as another lower airway disease symptom was also associated with daily reported nasal symptoms or hearing problems. And as you can see in the graph, with the presence of chronic rhinosinusitis. So despite there were a clear association between upper airway reported symptoms and lower airway reported symptoms, the study wasn't able to find out an association between chronic rhinosinusitis and spirometry objective findings, we can say, from spirometry. So these findings support further the concept of the unified airway in PCD, and suggesting that upper and lower airway disease occur interdependently, and that common management is very important in PCD. So as a linked project is the definition of ENT exacerbation. So a large consensus expert panel from Europe, Canada, Australia, and Japan was set up, and using a modified Delphi approach, they built up a standardized definition for otologic and sinonasal exacerbation in PCD, which is very important, and they can be used in clinical trials and in research in general. We will share with you otologic exacerbation as an example here. You can also see that the definition combines both patient-reported symptoms and also clinical examination signs, and it includes both major and minor criteria. So, yeah. So now I would like to talk about our current project, which focuses on the management of upper airway disease in PCD. I would like to say that the data analysis is still ongoing, but we will share with you some preliminary results, a few preliminary results. So the aims of this current project are to describe the medical and surgical practices of upper airway disease in PCD among different centers of the EPIC-PCD study. We would also like to identify possible factors that are linked with these specific management practices, and in some available longitudinal data to assess changes in these practices and also find out the possible factors that are related with these changes. And finally, we planned to conduct a short online survey that we would like to circulate it on ENT specialist of each center. So here we have summarized some of the results, as I already said. The preliminary results has to do with aim 1, and more specifically it is from a cross-sectional analysis of an available data set. Of course, these results and these numbers will be updated further in next steps with the final analysis. So in this analysis, we included 454 patients. As you can see, our sample of analysis had a median age of almost 19 years old. We can say that half of them were female and half of them male. 60% of them had situs solitus, 27% of them had hearing impairment at the baseline at the entry of them in the study, and 51% had bronchiectasis at baseline. So just to show you a bit the treatment overload of these patients, so 21% of these patients reported hospitalization, one hospitalization since the last clinical visit. And as you can see, the most frequent reason for hospitalization was lower airway infection in a percentage of 38%. 35% of the participants referred or had a use of antibiotics for an acute infection since last visit. And again, as you can see, the most frequent reason for the use of antibiotics was lower airway infection in a percentage of 70%. And we can also share to you that many of these patients had more than 2 or 3 hospitalization or even 2 or 3 times used of acute antibiotics since last clinical visit. So as far as we can say their baseline treatment, 30% of the participants had prophylactic antibiotics, and macrolides was the most frequent prescribed antibiotic class in a percentage of 75%. 23% of the population, of the sample population, used nasal corticosteroids, and the majority of them used nasal corticosteroids all year, not only during exacerbation. Nasal rinsing was also present and is what was also used by 56% of the population of the study sample. And again, the majority of the participants perform nasal rinsing daily. Nebulization was also used in a percentage of 10%. Again, the majority of the population, almost all of them, use it daily, and hypertonic saline was most frequently a saline solution used for the nebulization. Now, as we have already shared with you, we have created an ENT specialist survey, and we have circulated in all the centers of EPIC-PCD study. And we can say that we had all the ENT specialists, like one of each center has replied, giving us a 100% response rate for this specialist survey. So the main purpose of the survey was not to understand more and to expand our knowledge about the management of the upper airway disease, taking into account this clinical expertise of the ENT specialist of each center. So 14 ENT specialists completed the survey, 3 of them treating all children, whereas 11 treating both children and adults. So we have summarized here some of the responses. So as you can see, nasal corticosteroids are recommended by the majority and prescribed by the majority of the ENT specialists in less than 40% of the patients. And 57% of the ENT specialists start prescribing nasal corticosteroids in children from age of 2 years old to 5 years old. And also almost half of them, 43%, start prescribing nasal corticosteroids from the age of 6 years and above. So, yeah, and next one. So, as you can see here, the majority recommends nasal rinsing to almost all patients. Nasal rinsing seems to be part of the treatment plan, both during routine care and exacerbation, and the vast majority of the ENT specialists recommends isotonic saline solution in comparison with hypertonic saline solution, and this is seems to has no difference between routine care and exacerbation. We also ask if there is a preference in the combination of volume and pressure. So as you can see, the majority prefers to prescribe high volume nasal rinsing, either combined with low pressure devices or with high pressure devices. And when we ask since when they start prescribing nasal rinsing in children, almost half of them replied that they start nasal rinsing from earlier than 3 years in children with PCD. Finally, we would like to find out more about surgical practices. So we ask mainly for the most common and frequent surgical practices. As you can see, functional endoscopic sinus surgery was recommended by the majority of the ENT specialists in less than 40% of the patients. And this is the same image also for myrigotomy with ventilation tube insertion, whereas here we can see a difference in the percentages regarding children and adult patients. As you can see, children also are, in children is most frequently, of course, but than in adults. But it is also impressive to see that also in adult patients, this surgical practice can take place. And polypectomy. Polypectomy, it is was less frequently recommended, like in less than 10% of the patient for the majority of the ENT specialists. So what are our next steps in this current project? So we would like to continue with this cross-sectional analysis and the results I have already presented to you, and also try to assess factors associated with these different treatment categories. And in an available longitudinal dataset, which is almost 180 patients, we will describe changes in treatments over time in each different clinical ENT visit and assess factors that are associated with these treatment changes. And of course, we will not stop here. So as a linked study, we will prepare, we are planning to set, and we have already started to set a large, a large international panel of ENT specialists. And by adapting the eDelphi process, we would like to create consensus recommendation for ENT management. And we will use EPIC-PCD data and results that I have already presented to you in more detail, of course, and a detailed literature review that would be the basis of our discussion. So this project starts in January 2026, and it is led by Myrona Goutaki and Jean-François Papon. So we have, of course, other ongoing projects another planned analysis for EPIC-PCD study. So we have summarized here some of them. We plan to assess and examine physical activity and quality of life in PCD. We would also like to see the short-term evolution and progress of otologic and sinonasal disease in PCD over time, and also predictors of sinonasal and otologic exacerbations. So as far as the management of EPIC-PCD is concerned, as we have already said, so we plan to, the next steps are to continue recruit, of course, new patients from collaborating centers. We would like also to focus on longitudinal follow-up, which will give us valuable information and knowledge about the progression of upper airway disease in PCD. And of course, as Myrona already told you, new centers are more than welcome to join. So, this next. Yeah. And finally, I would like to summarize for the ones that are interested in joining EPIC-PCD study, a few steps that are necessary. So in general, the participation and in EPIC-PCD study is a simple process. So the first step is to contact us, have a communication with us, so we can share more information about the study and also about the steps. And one of the most important part is the ethical approval. This needs to be locally by each center, and this is because because of the different local law backgrounds. And the important thing to know is that the requirements in the ethical approval needs to be said that there is the possibility of contribution of pseudo-anonymized data in an international database. So this is a responsibility of each center that wants to enter the study. So if everything is okay and the procedure with the ethics goes well, then we will sign a data transfer agreement between, of course, the PI of the study and also the new center. And it's time when it's time for a publication, we will also sign a publication agreement for each different publication. So then the new center is already in the study, as far as the patient recruitment also has started, of course, and we will be in a continuing communication with the new center. So we provide online software REDCap access, which would be the databases, also information and technical support. And as you have already seen, the centers that are already part of the study, we will send monthly progress updates about the EPIC-PCD study recruitment and also important news that we want to share with you. And finally, as far as the patient procedures for patient recruitment is concerned, again, the procedure is not so difficult. So all patients of all ages that have a PCD diagnosis and that attend at least once a year an ENT clinical visit can be included in the study. You can, of course, communicate with your patients and discuss about the study in a clinical visit. And if they agree and they would sign the informed consent, and then the responsible collaborators of the center should also start collecting the data. First of all, the minimum requirements that Myrona has already described, and enter this data in the REDCap software database. And with this, we would like to thank you very much. We would like, first of all, to thank our PCD team members, all our collaborators of EPIC-PCD centers, past and current collaborators, and especially thanks to Jean-François Papon and Alexis Campos. We would also like to thank all people living with PCD and their families who participate, and of course, the funding that reassures the continuation and existence of the study, Swiss National Science Foundation and Swiss Lung Association. So in case if you want to contact us for any further information, we have put here our emails.
Wonderful. Thank you very much.
I stopped sharing so you can see us both better.
Yes. Thank you both very much. Those were excellent presentations. And I'm biased, of course, but it's the truth.
A bit
They
biased,
was excellent.
yes.
A bit. You gave us a wonderful overview of the past, present, and future of EPIC-PCD. And most of all, you made the previously neglected area of a rare disease not so much neglected anymore.
I have to say, Yinting, that whenever I was trying to put together this intro with Vasiliki, and I was thinking, we soon will start saying it's not so neglected, because it's not just EPIC, but I think the efforts that we do with EPIC also somehow motivated or maybe inspired a lot of other efforts locally in many clinics right now. So we see more and more published studies, or we see a lot of effort from North America the last few years on the upper airway. So the evidence that comes out is richer and richer. So we finally understand this topic much better.
Yes, not just richer, but also raising awareness for PCD and therefore leading to better diagnosis as well. So thank you both very much. Let's kick off the Q&A. Let's start with Mine.
Okay. Thank you again. Great talk, Myrona and Vasiliki. Actually, I wonder, do you have any upper airway microbiology data about PCD patients? And these data predictive of the lung disease progression?
So we do collect microbiology data. An issue that we have with the upper airway microbiology data is that we soon realized it was one of the things we wanted to do with the study. We hinted quite frequently on it and the possibility of the sinuses to be maybe the bacterial reservoir. But what we wanted to see is really if upper airway microbiology can predict lung function or even how it's associated with lower airway microbiology. Very few centers collect upper airway microbiology routinely. And even those that they do, very few of them do it at the same time point. So this is something that we're not officially saying that we have underway, but we have been discussing with some of the centers that participate in EPIC, and they have shown interest, for example, with Jean-Francois, who is also in the call, and a few other centers, that we would like to do a nested study where we collect upper airway samples together with lower airway samples, and then we have anyway all the other data, so we will be able to answer hopefully such a question in the future.
Thank you.
Thank you.
Yes, that was an excellent question. I think this has been actually a recurring question during all those EPIC-PCD meetings, and actually that many centers asked us, and then we just asked them back. Are you doing that? Of
Yes.
course, we can only collect the data if you are actually performing them with those patients at the same visit of the upper airways plus any sputum probe. So
Okay,
I
so
have. Yes?
Another perspective that I have discussed a bit with one of the newly recruited center is that even if they take some samples and they culture them, because of this patient they have taken daily this period prophylactic antibiotics, these cultures may be negative, although they had in the past some positive ones. This is also something that have been raised as a concern.
Mm-hmm.
Yes, very good. Now, I have some questions. You listed an overview of the reasons of hospitalizations, and there were 20% of the hospitalizations that were declared as other reasons. Did the centers declare or describe what those other reasons were?
Yes. Yes, this is a high percentage, we can say, and there are a lot of for other situations. Although the question is more specifically for PCD, most centers also collect it and include data also for other diseases. So some of them has to do with this. But I would also like to raise a concern about the upper airway disease. So you would have seen that in this cross-sectional analysis, upper airway disease as a reason of hospitalization was at 2% of the population, but for the upper airway infection. But in the elective surgery, which was also a high percentage, like 20% almost, most of these cases were due to surgical procedures for the upper airway disease management. And this is also needs to be taken into account, because it is not only the lower airway disease that it is the most burden. And yeah.
Yes, very good input. Thank you. Mina?
And the next question is Mina Hizal. Considering that ENT symptoms in PCD vary across seasons, how do you think this seasonal fluctuation might affect the value of a single annual ENT assessment?
Well, the aim is not to have a single annual ENT assessment. That's why we say that this depends on the center. I don't think many centers have the capacity to change their local SOPs, but what we ask the collaborating centers is to contribute data from all the visits. So some patients have actually visits every 3 to 4 months, and some have at least twice a year, because this is a very valid point. I think the issue is mostly with adults. A lot of the adult patients only go to the ENT specialist once a year. And I think if we want to get more valuable information on the seasonal fluctuation, that we show some data, and we have published some data, as Vasiliki saw, it is very important to be able to have measurements or questionnaire data from different seasons. We try to do that also a bit in other studies. The follow PCD questionnaire, actually, at least for the symptoms, it is used not only in EPIC-PCD, but in other research also. So we do that also with the Living with PCD study, which is an online participatory study, and we collect this data from people with PCD worldwide about symptoms and upper airway symptoms. And we have the different seasons that they have completed this questionnaire. So this is something that we want to look more into that in the future. But from a clinical perspective, I think that means that one visit per year, especially if it's on a season that usually a person doesn't have a lot of symptoms from the upper airway, might be actually misleading for the burden of upper airway disease.
Yes, very true. Thank you, Myrona. I have a question. You also described that 30% of the participants were taking prophylactic antibiotics. And do you know whether those were also the ones that had fewer exacerbations? Did you look into that data?
Well, we don't have data on exacerbations yet, because the definition is just developed recently, so we have not started collecting this data. That's why Vasiliki saw that this is something that we want to do in the future, because this is a very valid point, to not say only for the lungs, where the definition exists since quite some time, but being able to use the new definition for sinonasal and otologic exacerbations to also see if prophylactic antibiotics help with that.
But what about those hospitalizations for pulmonary infections?
I think Vasiliki has not checked that. Actually, Vasiliki, you didn't mention, these are just the descriptive data that she has shown. She also plans to do analysis with some regression models so that we can identify some factors that might inform management strategies. That would be a good thing to look into, if the patients that get the prophylactic antibiotics have less hospitalizations for infections.
Great.
Hi.
Jean-François?
Hello. Hello, everybody.
Hello.
Thank you very much for the presentation, both of you. I was wondering if once the diagnosis of PCD is made, is the treatment differ compared to the period before having the diagnosis?
We don't have this data. All the patients enter the study after being diagnosed.
Yeah.
But this would be something that we should discuss in the consensus management group, because I think there should be some recommendations in general for people with high clinical suspicion, even before diagnosis, if it makes sense to avoid some management strategies that we know that don't work with PCD.
But it can be interesting to look for that if the once you explain the diagnosis of PCD and you explain the treatment, if the patient changed, for example, do they do more intensification of the nasal lavage or
Absolutely,
or the opposite? Are there some patients that stopped the treatment because they are demoralized or
because of having PCD? Yeah.
Could be. With some more questions, Mina?
And there is a comment from Miguel. Thank you so much, Myrona and colleagues. It's a great project and very necessary. We will try to participate in our PCD units.
Well, we want to thank Miguel because they are one of the centers that participate in EPIC-PCD, and as all our collaborators, I think there are several today on the talk on the call, and they really contribute fantastic data that help us understand so much better upper airway disease.
And the other question is from, again, Mina Hizal. Do you think nasal polyps in PCD require a different approach compared to other chronic sinus disease?
I don't know. Can I ask help from the audience? Can I ask like Jean-Francois or one of the ENTs to help with that? Because I think this is much more of a management question that I cannot. I would say in principle, probably not. But I certainly do not have expertise in that. What do you think, Jean-Francois?
Yeah, we have two experts here with
Yes.
William. So, in my opinion, it differs in terms of not doing a wrong treatment. For example, the patient that have polyps may not respond to biologics because if you prescribe biologics that are focused on type 2 inflammation, in nasal polyps of PCD patient, inflammation in the majority are non-type 2, so usually they don't respond to biologics. This is what Miguel said.
Yes, Miguel writes the same, exactly.
But for the rest, I think it doesn't differ, especially for surgery.
No, we treat according to the EPOS statement.
Yeah.
And yeah, just to echo, I think there was a study done in CF that showed that there was a sort of minimum improvement with usual steroids targeted to type 2, like Professor Papon says. So, but realistically in Southampton, we end up just treating the same according to EPOS.
And when you operate the nasal polyps, there's not so much patient that recover the olfaction compared to the typical type 2 nasal polyps. When you operate the typical type 2, usually they recover more or less olfaction, but for PCD patient, it's not so obvious.
And if I can make a comment on the polyps, especially because Miguel wrote on the chat that they're very rare, I actually have to say that when we started the study, I would expect a higher percent of people with PCD with polyps. There is this impression that polyps is a very major aspect of the sinonasal symptoms of PCD, while there are other issues like the hypertrophy of the
inferior turbinates.
The turbinates, that it is a much bigger issue, and still a lot of patient information, for example, that they exist around, and I think also information for doctors. They say for the sinonasal disease that polyps is a major thing for PCD, and I think this information we need to start correcting a bit.
Yeah, and compared to CF, it's clear that nasal polyps are less frequent in PCD, but in the EPIC-PCD there are a lot of children, and you know that polyps in PCD appears mainly after 20, 30 years old. So,
but more than half are adults. I don't think. I think more than half of our people are actually adults. It's not. It's not too surprising.
But when you look at the literature, usually the nasal polyps are between 20 and 30% of the adult population.
Yes, I think also in our study, most of the polyps come from adults. So if we see it specifically from adults, it would be a bit higher.
Thank you both.
Oh, that's interesting. There is an interesting comment with a patient with PCD. He has dupilumab for 4 years. And that's it, very interesting, because we are performing pathology analysis of the polyps of PCD patients. And sometimes when the polyps are rich of eosinophils, it could be a good indication of biologics.
Great.
If it's not too much infected, for example, it could be interesting. Thank you.
Very good input and comment. Thank you. I have one more question. You also described the percentage of patients who did nebulization. I guess that's the nebulization of the lungs, right? Pulmonary. Not nasal.
Sorry?
No, that's for you, Vasiliki. It was upper airway nebulization.
Yeah.
Upper airway nebulization.
Yes.
Oh, very good.
Yeah.
Yes. Because from what I noticed, that is actually probably the thing or the treatment that if people like to drop it, they prefer to drop that since they felt like it's not necessary. But that's good to see. All right. More questions, Mina?
Yes, I have one question again. Which ENT phenotypes in PCD are associated with the poorest prognosis, and how does this correlate with the underlying genetic defects? Do you have?
So we have done in the published paper, we try to see if there are any associations with genetic groups in the form of ultrastructural defects, and we have not found any signs. And I think I have a personal theory in that. I actually think that there are very specific characteristics that they are clearly associated with genetic phenotypes, and common problems like problems from the upper airways and from the lower airways, more or less, most of the people do. There are differentiations sometimes in the frequency, but I don't, like some years ago would say that maybe there are people that they have only upper airway problems or only lung problems. I don't think that there are people who are completely free of upper airway problems. For prognosis, long-term, this is what we want to see in the future, because most of the data that we have analyzed right now are baseline data. So some of the work that Vasiliki and Nena will do in the future really will focus on trying to see if getting more severe disease with time might be associated with some of the genetic defects. But I personally really doubt that, to be honest, for the upper and lower airway symptoms.
Thank you.
Thank you. And Miguel also gave a comment. He said, but I think in many PCD patients, little polyps are in the middle meatus. Also, a patient can have PCD and, on the other hand, a T2 airway inflammation.
Yes, this is absolutely true. I mean, a T2 airway inflammation is not uncommon also in the general population, and many people that they have a rare lung disease like PCD, they might also have this as a comorbidity. So in that case, that would be a very valid point. Thank you for this comment.
Yes. Yes, Trubas also says, thanks for a great presentation and discussion. That is absolutely true. Those were excellent presentations. We are very much looking forward to what's coming next, because those aims sound very, very interesting and are very crucial for the management, and also just, again, to then also improve PCD care for the patients. So thank you both very much.
Thank you very much for inviting us today.
Thank you very much.
Thank you.